All right, it's been a couple of weeks. Let's hop back into it. We've got 9 studies on the ticket, and well, I don't know much more of an introduction other than let's just go. So let's start first with a couple of them that cover a similar topic, and that's going to be chronic pain. And these overlap in different ways, so I'm going to probably bounce back and forth between all of them up top there. The first one we're going to talk about deals with stress, pain intensity, and work productivity in individuals with chronic pain. And surprise, surprise, like the other ones I have up at the top, they find very similar and overlapping things. This one in particular found that pain intensity and stress were significantly associated with reduced work productivity. Okay. They think, the authors, that implementing strategies for pain management, stress reduction, sleep improvement, along with healthy habits in the workplace, is recommended to mitigate those financial losses. And those losses are not just on part of the employee, that's also on the business that they're employed in, that we're going to see in future studies. So this has been a little bit of a passion project where part of my practice, or frankly, most of my practice, is meeting patients where they're at, and oftentimes that is actually at their place of discomfort, where they're feeling the pain. So different avenues of healthcare we have looked into and are actively pursuing are going to be going to different gyms and working with people while they are actively in pain while they're working out, because that's something commonly that I hear. It's like, hey, it's not that big of a deal until I try and exercise, and it's something that keeps me from exercising, which has compounding effects, which we do not want. So we are going to gyms to actually work with people while they are at gyms. Another thing that we are trying to do is find avenues to work at places of employment with employees and employers that are amenable to the idea that having a staffed on-site musculoskeletal health expert can mitigate and reduce what we're going to be talking about in the next studies, which is frankly significant financial costs to both the employer and the employee if this person is suffering with chronic pain. That is both direct costs to their health care as well as indirect costs, such as time away from work, work productivity while they are there, time off to go to those medical appointments, or time off to deal with the chronic pain and the other conditions that people have with chronic pain, such as depression, insomnia, etc. This is an effect that we can effectively reduce if we develop adequate strategies to do so. So next study, association between chronic pain severity and falls. This one basically found that among the other things that you want to look out for with people with chronic pain is they're at an increased risk of falls. That may be because once you deal with chronic pain, your body kind of goes through this fun little triage process where it dials up or dials down certain sensations, which can include your sense of balance to fight or stem off what it's going through when it's dealing with chronic pain. So if you're in chronic pain, not only do I have to consider the pain that you're going through, I have to consider the pain the environment is in. So how are you doing as an individual? Are you sleeping adequately? Because a lot of people in chronic pain are not. Are you eating adequately? Are you having meaningful interactions at home? Do you find a sense of community? Are you emotionally um, do you have enough in the emotional bank to go through this chronic pain condition? Do you have enough mentally for the same thing? Do you have a good sense of balance so that we're not at a risk of developing a secondary injury because of your chronic pain? All of these things have to be considered and play into one another, either directly or indirectly. Ah, here's one of the other ones that I was referencing as far as an actual cost. They wanted to take a look at putting an actual number to people that suffer with chronic pain, and is there a financial money dollar sign that they could put next to it? And once they took a look at the economic costs of chronic pain in 2021, here's what they came up with. So first, they took a look at 6,445 adults, representing roughly 65.8 million when they projected it out, with chronic pain, using actual diagnostic codes in the survey. So this isn't just a questionnaire. This is people went in and were diagnosed actively as having chronic pain. So this is a working diagnosis that they had here. And what they found was, through direct medical costs, indirect morbidity costs, et cetera, they evaluated or estimated the economic burden of pain being $8,068, with an additional lost productivity of $3,000 per person compared with individuals without chronic pain. That is insane. Like when you actually think about it, let's say you have a business with 100 employees and 10% of them, so 10 people, have chronic pain. Those 10 people are going to combined spend out of their pocket an additional $80,000 into the healthcare system, as well as costing from a productivity standpoint $30,000 to the company. Okay? Like just put that in perspective. That's the average. That's not exactly a giant population. Like there's several businesses that have more than 10% because of the nature of their job. Like around here, it's a lot of blue collar, and I can pretty well and bet say that more than 10% of any given workforce around here is in some sort of chronic pain, just given the lifestyle around here. So that financial burden is huge. It's one that I can confidently say we can mitigate with offices like ours. So if you're hearing this and you see these numbers and they're shocking to you, reach out. I'd love to help you. Because like I said, developing strategies where we work on site to take care of this, like frankly, you could work with me quite a bit. If you're spending an additional $8,000 for this chronic pain, that is a lot of visits you can just work with me to knock it out of the park. And $3,000 in lost productivity, like you just get a couple of employees costing that much money, like we're gonna make you money in the long run if we tackle this. So yeah, this is just something that, again, you can see why it's a passion project. It is costly in all realms, financially, socioeconomically, socially, emotionally, mentally. Like there's no good thing about just brushing this problem under the rug. All right, what we say matters. So why on earth do I take so much time with each patient? Why do I try and get to know them? And why am I so focused on communication with each one of my patients? Well, because words matter. Whether it is through known mechanistic reasons or placebo reasons, what we say in an interaction such as ourselves, when it's a doctor-patient relationship, or frankly any relationship with a healthcare provider, words matter. They have power for several reasons that I don't have time to address here. There's different power dynamics, expert dynamics, knowledge dynamics that all play into why people take things that you say probably not harder, but in a deeper way than a lot of healthcare practitioners even understand. So if I say something, oh my gosh, you have such bad knees, you should never do X, Y, and Z again, that's going to have a significant impact, and not for the better in most scenarios. Like that's going to keep people from that's going to keep people avoiding activities that actually may be better for them based on my prejudice. That may set them up for a worse prognosis because they go into their healing factor with that understanding of, oh my gosh, he's the worst I've ever seen. That means that I'm doomed to suffer, yada, yada, yada. And setting that up is something that we have to understand that we have the power of when we're a healthcare provider. Put another way, if I say, something along the lines of, oh, this isn't so bad. If we do X, Y, and Z, we should see this by this point and that by that point. It sets up a different healing prognosis because, again, what we say matters. If I say good things, even if it is not mechanistically, like, oh, it's not placebo, it's this, or it is, I don't care. All we know is that what we say matters. So that's why it takes so much time to figure out effective communication strategies with each one of my patients so that we leverage everything that we can to make sure that they are better after spending time with us. Okay. Next up, something we treat in the office. It's now getting more and more recognized: cranial nerve entrapment. This can be considered a sciatica of the back. So where people think they have sciatica, where it's pain from the glute region on down their leg, people have oftentimes this vague pain radiating around their back, around their hips, and maybe even into their thigh and groin. This is something that we catch quite often in the office. And I'm glad to see it's getting more recognition, because given our current lifestyles, I'm not surprised that this diagnosis in and of itself is creeping up. So you have nerves that come out from the back where the mid back meets the low back. So essentially where you have ribs meets the part in your low back where you don't have ribs. And around there you have nerves that fan out to give your brain information about the low back, the outside of the hips, and part of the groin region. Um, and a lot of the times, given our propensity to sit and then sometimes going from desk warriors into weekend warriors, where it's a lot of sedentary activity going into a lot of vigorous, maybe exercise related activity, a lot of the times this area can get extra irritated, and then people have this irritating back pain that doesn't quite go away with any one particular treatment or on its own. And sometimes stretching helps, sometimes it doesn't. Um, it's something that if we diagnose it right, we can give the right interventions for it. We can give the right mobility drills and exercises for it, as well as coach people through some of the potentially concerning symptoms with this. Because once in a blue moon, you will actually get through a chain of events, because your nerves can be thought of as wires, and if you uh, basically break a fuse, so to speak, and I don't want to, basically if a fuse gets switched, you don't have power to a whole area. You are playing with electricity in the sense that some people with this irritation, even though it is from the low back, can have genital symptoms like genital pain, numbness, paresthesia, etc. So in men, that would look like testicular pain. That's not as bad as testicular torsion. In your ladies, you can have labial pain or discomfort, and those are not necessarily things that are calm. Like if you have those symptoms, you're not going to just like, oh, it's no big deal. You're probably going to ramp up a little bit and go like, oh my gosh, what is happening? So if we diagnose it right, we can tell patients that, as long as you're not feeling X, Y, and Z, which would indicate a worse condition, as long as you're feeling A, B, and C, it is common that patients feel this. So if we treat you right, keep an eye on it, and if it goes away in this amount of time when working with us, great. If not, then we can refer you out to make sure that we're checking all of our boxes and treating you right. So it's something that I'm glad that is getting additional recognition in the literature. All right, we've only got a few more. TMD and tinnitus. So jaw pain and tinnitus, they are unsurprisingly very heavily interlinked. The jaw area is a hotbed of overlapping neural structures, as well as directly connected to the upper neck, which in and of itself is a hub of nerve centers. So this whole area of your body, this mid neck up and neck forward to your face, it's very, very sensitive, and tinnitus is very, very annoying. However, this is a correlation that we can find as potentially uh, to calm those people that have jaw pain and coach them that, hey, it's not uncommon. In fact, it's extremely common that you have tinnitus and vice versa. There's a lot of overlapping structures. You're not going crazy. This can be frustrating, but we at least have an understanding relationship between these issues. Can't guarantee that it'll go away if you fix one or the other, but we at least have a reason so that we understand you're not suffering, or you're not necessarily suffering from like an acoustic neuroma, which is a nerve tumor uh, by the ear. So it's a great way to communicate calm with a patient who's going through something that can be distressing, because tinnitus has ranges. Like it can be just mildly annoying to very distressing depending on how loud it is. But what they saw was 17 studies were included. A few showed risk of bias among patients with temporomandibular disorder. Almost 60% displayed tinnitus. Now, flip that, among patients with tinnitus, most of them suffered from some sort of temporomandibular disorder. So these are very heavily interlinked. Next up, the efficacy of kinesiotaping combined with exercise therapy on patients with knee pain syndrome. Systematic review. I'm going to cut to the chase here, right to the conclusion. The current evidence indicates that the combination of taping and exercise training significantly enhances knee function and single leg hop test results in patients with that knee pain syndrome. Furthermore, an intervention duration exceeding 4 weeks is recommended, as it may lead to more favorable outcomes. So something that we offer in the office is taping. We prefer dynamic tape, biomechanical taping, because it has additional benefits with our patients, because we can actually tape to help reduce the load so that we can just have another factor when we're just doing what most practitioners do, and that is load management, getting you to do some of the most tolerably difficult things your body can handle at the time to get it to heal the way that it needs to heal. So this is something that, it's a hotbed on social media. You see people doing crazy, wacky tape jobs, taping people so they look like mummies. That's overkill. But if you find a practitioner that knows when, where, and why to tape, it is something that, especially in the short term, so in the acute, subacute stages of healing, is phenomenal. So if you have something like, let's say, an ankle sprain that you did really, really good, and your ortho said that you're gonna probably have at least 3 months of recovery because you did it right. Well, we can, after you get into the subacute stage of healing, after a lot of that inflammation is down, um, tape it. Well, okay, we can tape it when it's fresh and hot and swollen, but we do it differently, not the way that it does in the evidence here. But anyway, I digress. When you're in that subacute stage, when you're starting to load it again and it's a little bit ginger, like, hey, it's still sore, but I know I need to move it. Let's slap some tape on there to help control the load and get you moving faster. Like that's its purpose, is just load management and getting you to sense the injured area better as you get out from the injury state. Speaking of injury, if we're going through something like an operation, a surgical procedure, you can consider, especially since we're in the upper Midwest and it is deep winter, consider adding in vitamin D. Vitamin D is fantastic because, well, let's just say what the study said. First up in the results, 10 studies met the criteria, yada, 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 the business. Studies suggested that vitamin D enhances healing through extracellular matrix remodeling, so outside of the cell remodeling, and inflammation modulation. The quality of evidence is low. Most studies are retrospective. Half the studies relied on large administrative databases to talk about it. However, considering the cost of vitamin D, which is phenomenally low, considering how many people like magnesium are chronically low in this area, even if the evidence is low, I will still make the recommendation for a majority of my patients to take it for those reasons. Even if the evidence is low and it's not a guarantee that it will enhance the healing, most people are deficient around here. There is an extremely high dose limit. Like, it's not going to hurt you. You would have to be, I don't know how much vitamin D you'd actually have to like buy to actually get to a toxic level, but vitamin D is extraordinarily safe. It is missing in this area, especially in winter. It has other synergistic effects with other parts of your body. Um, so there's no reason for us not to prescribe vitamin D. And even if it has the chance to enhance healing post-operatively, I might tell my patient, even if they're taking vitamin D, like, hey, if you're having this operation for the next 3 months, just double or triple the dose. You're not going to hurt yourself. And there's only the chance that you're going to improve your healing from this operation. All right. Now, again, like everything else, they have that little disclaimer in there. Future studies are needed to determine optimal supplementation strategies, dosages, et cetera, but that's for a future discussion. And last but not least, the effectiveness of thoracic spine manual therapy in treating shoulder impingement syndrome. Now, again, I'm not a big fan of shoulder impingement syndrome, but that's what they use in the literature as far as talking about a symptom or an area. What did it find? Well, shocker, shocker. If you treat a connected area to the main problem, you typically improve the problem. Put another way, yeah, your shoulder is a highly mobile joint. Where is it connected? It's connected right. That's right, adjacent to the neck and mid-back. So you have this arm bone connected to this shoulder blade connected to your upper back, the T-spine area. So when we have people that complain of shoulder pain, oftentimes you are looking not just at the shoulder, but around the area. So you're looking at the neck, you're looking at the back, because these things have wonderfully, honestly, it's kind of like anatomically beautiful how it interacts, but it also leads to clinical considerations that we have to discuss here. If your person who looks at you, oh, I have shoulder pain, and they're only poking around the shoulder and deltoid muscles, they're too hyperfixated and focused. There are so many things that feed into shoulder pain, it's ridiculous. You've got the neck, the mid back, the shoulder itself, the muscles, you've got vein. Oops, sorry. Might cut out for a second there. Um, you've got arteries, blood vessels, veins, nerves. There's a lot to consider. And yeah, a lot of the times we get lucky and it's something local, but if you're not looking globally, so if somebody's checking out your shoulder, isn't looking at the neck, isn't looking at the mid back, isn't doing some sort of management strategy, whether that's manual therapy, mobility drills, exercise, etc., that addresses the entire area, you're going to probably only get so far in your care until you find somebody who does. So glad to see that more and more evidence is backing up the approach we take at the office, and that is a more global look at the human body. That's all I've got for this week, well, the past 2.5 weeks. So stay with us, and we'll have another video for you next week. Bye-bye.